Chairperson Swankar Sahab, Vice Chancellor Gulati sir, and Pro Vice Chancellor Kapoor sir, my seniors, my fellow colleagues, and my dear students. It gives me immense pleasure to introduce my department to you all. The Department of Gastroenterology was founded in the year 2015, and the DM courses started a year ahead in 2016. Initially there was only one seat, then it increased to 3 seats by the year 2020, and by now we have actually cleared 13 students who have passed till now, and we have in faculty 3 full-time professors and 1 assistant professor. Myself, Dr. Sandeep Nijavan. I have headed the department of SMS previously. I am in the editorial board of digestive endoscopy, and when I was young I actually indigenized around 25 endoscopic instruments. I have edited 3 books, contributed 5 chapters, and I have 175 publications to my credit. Dr. Rajat Bhargava, Dr. Akash, both are professors in the department, and Dr. Sumit Yadav. All 3 are very young and energetic, and they pursued the academic excellence as well as patient management. As far as learning facilities are concerned, we have around 4 to 5 classes per week. We have active academic learning during the classes and the rounds. Then we have hands-on training always there for residents during the endoscopies. We have interdepartmental lectures and lectures by the invited faculty. As far as OPD and IPD data is concerned, in last 4 years from 14,000 OPD patients has gone to 18,000, and the inpatient care from 1,200 has gone to 1,800 per year. We have endoscopic suite which is actually well equipped, and there is a gradual rise in the number of endoscopies, colonoscopies being done. We have a modern ERCP suite with all advanced equipments. Now we have added cholangioscopy in that, and there is a gradual rise in the number of therapeutic ERCPs being done in the department. In last 1 year, we have added few more things in our armamentarium. We have started capsule endoscopy, which is very useful for mid-gut evaluation, especially occult bleed and anemia. And then we have ultrasound, endoscopic ultrasound. Well, I'll come to later. Then we have added cholangioscopy, which actually gives you evaluation for indeterminate biliary strictures as well as dealing with very difficult stones by laser. Then we have single balloon enteroscopy again after the midgut evaluation for therapeutic purposes. For finalizing the diagnosis, we need single balloon endoscopy. We have solid state manometry in the department, which is first in Rajasthan, and it is for the evaluation of esophageal and rectal manometry. We have started EMR ESD. Actually, it is for bigger lesions, mucosal lesions, in which actually you do almost dissection like a surgery. Endoscopic ultrasound for last maybe less than a year we have, and we have conducted diagnostic endoscopies to the tune of 120, and we have therapeutic FNA, FNB. We have started doing therapeutic cirrhosis drainage of walled-off necrosis, and pancreatic fistula. Therapeutic EUS being performed on a newly actually created anesthesia platform. So we have actually 2 therapeutic endoscopy tables running together thanks to the anesthesia department for that. Then these are the books which have been edited by the department on gastroenterology, endoscopy and liver. Then we have some recent chapters and publications. These are the recent publications. We had conferences attended by the residents. These residents go one by one on rotation to the national conferences. They presented papers, hands-on training, and then we had 4 conferences in the department in last 1 year. This is the first one, the therapeutic US by Dr. Vikas Singla. Then we had Dr. Srihari actually, who conducted a workshop on cholangioscopy. Then here we had Sandeep Shah from Ahmedabad, who conducted a workshop on manometry. Then Mukesh Kalla actually we had 2 cases of ecclesia for poem, which was conducted by Dr. Mukesh Kalla. Then we had Dr. Pankaj Shimal. So for the mid-gut evaluation, we had endoscopy workshop. Then we actually had public awareness programs throughout the year, annual day celebration in the form of World Hepatitis Day, Liver Day, IBD Day, National Doctors Day, and special recognition on the Republic Day for Dr. Rajat Bhago and Dr. Akash. The future plans are to have breath tests in addition, then AI application in endoscopy and third space endoscopy. We are thankful to the Management Committee of Mahatma Gandhi for the upcoming Center for Digestive Diseases by the end of this year, with all GI and allied specialties under one roof. So thank you very much. Now I'll invite Dr. Subham to take the proceedings further.
Thank you, sir. Good morning to respected ML Sankar, sir, all dignitaries, my seniors and fellow colleagues. I'm Dr. Subham Garg, third year resident, Department of Medical Gastroenterology, and I'm presenting a case of usual cause of pain abdomen with unusual complication and management under the guidance of Dr. Sandeep Nijavan, sir, Senior Professor and Head, Department of Medical Gastroenterology. Patient is a 26-year-old unmarried male student, a resident of Crawley, Rajasthan, belonging to low socioeconomic status, presented to Mahatma Gandhi Hospital with chief complaints of pain in upper abdomen for 5 days in July 2025 and shortness of breath for 2 days. Patient presented with pain abdomen for 5 days, which was located in mid-upper abdomen, acute in onset, preceded by alcohol binge 2 days before, continuous, boring in nature, with radiation to back, and was relieved on bending forward. Pain was such that it was not relieved on oral analgesics, but it was relieved on parenteral analgesics. The pain was associated with mild abdominal distension. There was no history of associated nausea, vomiting, retrosternal burning sensation, fever, jaundice, or obstipation. Patient also developed shortness of breath 3 days after the onset of pain abdomen. The breathlessness was continuous, non-episodic, and was not associated with wheezing. There was no history of chest pain, palpitations, hemoptysis, or syncope. There was no history of cough or purulent expectoration. There was no history of sudden onset pleuritic chest pain, calf swelling, or prolonged immobilization. There was no history of paroxysmal nocturnal dyspnea, prior orthopnea, or chronic exertional breathlessness. There was no history of any decreased urine output. In the past history, there was no past history of any surgery, no history of diabetes, hypertension, asthma, or TB. No history of any similar complaints in the past. In the personal history, patient is vegetarian by diet. He takes alcohol from approximately 8 to 9 years. That is, he consumes 375 ml whiskey, that is half bottle, 3 times a week, which is roughly equal to 360 gram per week of alcohol, which averages to 50 gram per day. His last intake of alcohol was 2 days prior to pain abdomen. He is non-smoker and has normal bowel and bladder habits. In the treatment history, patient was admitted at a private hospital in Kota, where he was managed with IV analgesics and IV fluids. Patient underwent blood investigations, ultrasound whole abdomen, and CCT abdomen. There was no significant improvement in symptoms during his hospital stay for 4 days, after which patient presented to Mahatma Gandhi Hospital. There is no history of any drug allergy. In the family history, there is no significant family history. So, as a whole, in summary, a 26-year-old male, alcoholic, presented with complaints of acute onset, severe epigastric pain, and mild abdominal distension for 5 days, shortness of breath for 2 days, with history of hospital stay and treatment without any significant improvement. So now I would like to ask the audience, what could be the possibilities based on history?
For the benefit of residents, please explain what is the definition of an alcoholic, because still many students, when presenting history, they say that he is an alcoholic, although he may be taking alcohol only occasionally and a social drinker. So what is the medical definition of an alcoholic, and does he fit into that?
Sir, alcohol consumption for regular alcohol consumption daily for more than for many years, for more than 5 to 6 years.
Actually, it depends on the amount of alcohol which we calculate by gram per 100 ml. So if it comes down to that toxic state, that is one which leads to organ injuries. And the other thing is that his social as well as family history is actually bad with the alcoholism. And alcoholics who start taking alcohols since morning, those are the actually alcoholics which are taken very significantly. It's the amount of alcohol for liver, amount of alcohol for pancreas which is fixed, which daily intake will cause toxic injury.
And I think there has to be an element of addiction also, that withdrawal symptoms happen if abstinence happens.
Yeah. Yeah, actually nowadays we use more the term alcohol use disorder.
Yeah. So there is a specific definition.
Defined as physical as well as psychological dependence on alcohol. So psychological means lack of use leads to craving, and physical is abstinence leads to tremors and other. So physical as well as psychological dependence is what is alcohol dependence syndrome. The colloquial term for which may be alcohol.
There is a specific scientific definition of binge drinking. What is that? Alcohol level exceeding, I think.
So 0.08, so blood alcohol concentration of more than 0.08.
जो पुलिस वाले देखते हैं वो
That is 0.03. That is 0.03.
So possibilities. कोई तो बोलो. One. 2 days before alcohol binge. Yes, go ahead.
I think it is 3 days. So the pilots are prohibited to take alcohol within those 3 days. They avoid it.
So with this history, we have the following possibilities. That is acute pancreatitis, peptic ulcer disease penetrating, acute cholecystitis, left lobe liver abscess, intestinal perforation, acute mesenteric ischemia, acute portal vein thrombosis, and intestinal obstruction.
So how will you explain the shortness of breath in options 2 to 8?
So in acute cholecystitis due to inflammation, there is possibility of due to pain, it can be possible that shortness of breath can occur. In left lobe liver abscess due to reactionary pleural effusion, and in intestinal perforation, due to peritonitis, there is possibility of respiratory distress, and in intestinal obstruction. So these I have kept in less likely because it is due to epigastric pain, so more likely due to epigastric pains. So with these possibility, we went for the examination. Patient was examined in a well-lit room with proper verbal consent. Patient was conscious, oriented to time, place and person. Vitals at presentation were pulse of 106 per minute regular, BP 122/82 mmHg in right arm supine position. His respiratory rate was 24 per minute. He was afebrile and his saturation was of 92% on room air. His weight was 75 kg, height 176 centimeter, BMI 24.2 kg per meter square. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy and pedal edema. Patient was on abdominal examination. Patient was inspected in a supine position with legs flexed, arms on the side, and exposed from navel above to mid thigh. Abdominal fullness was seen in upper abdomen with central inverted umbilicus. All the quadrants move equally on respiration. Normal abdominothoracic respiratory movements. No scar marks, dilated veins. pulsations or visible peristalsis, no swelling seen over the abdomen. External genitalia was normal. There on palpation, there was no local rise in temperature. Abdomen was soft. Tenderness and guarding was present in the epigastric region. Rigidity was absent. Liver, spleen, and kidney were not palpable. All hernial orifices were normal. Digital rectal examination was normal. There was tympanic note all over the abdomen on percussion. And on auscultation, there was sluggish breath sounds and there was no bruit present. On respiratory system examination, there was bilateral reduced air entry in infra-axillary and infrascapular regions with dullness on percussion in same areas. There was no added sounds were present. Cardiovascular and central nervous system were normal. Now, after both the history and examination, I would like to rule out some of the possibilities I kept after history. Firstly, in acute cholecystitis, usually the pain is in right upper quadrant, but in 10 to 20% cases, it can occur in epigastric region. But the pain usually in cholecystitis lasts for several hours rather than days. Also, there is no history of any biliary colic present. There is no radiation to the shoulder present, and no jaundice is present. Also, the Murphy sign was absent on examination. Secondly, I would like to rule out left lobe liver abscess, as the pain in left liver lobe abscess is epigastric severe, but it is usually associated with fever, and also jaundice can be present, and on examination tender hepatomegaly should be there. Then in intestinal obstruction, pain is usually cyclical, abdominal distension is prominent and is associated with vomiting, and on examination there should be hyperactive peristalsis present, which is absent in our case. Then in perforation, pain is epigastric and severe, but pain can be epigastric and severe, but there is no guarding, rigidity, and rebound tenderness is absent in our case. So we are left with four possibilities, that is acute pancreatitis, peptic ulcer disease penetrating, and acute mesenteric ischemia, acute portal vein thrombosis. With these possibilities, we went for the investigations. The patient came with some of the investigation done outside on day 1 and 2, following which the required investigations were done on day 5 at Mahatma Gandhi hospitals. His blood investigations revealed neutrophilic leukocytosis and mild transaminitis. His amylase and lipase on day 2 were 1435 and lipase was 1061, which was 3 times the upper limit of normal. On ABG, PaO2 and FiO2 was 230. Rest of the investigations were normal. Chest X-ray, X-ray abdomen, and ECG were normal. Patient also came with ultrasound done outside on day 1, in which showed liver was enlarged, hepatomegaly was present with fatty changes in liver, gallbladder was distended, and there was bulky pancreas present, and MPD was not dilated. Now I would like to invite Dr. Diksha from Department of Radiodiagnosis to discuss the CT scan which was done on day 5 outside.
Thank you, Dr. Subham. I am Dr. Diksha. Good morning, esteemed dignitaries, faculty members, and residents. I am Dr. Diksha Gupta from the Department of Radiodiagnosis, and I will be speaking about the radiological findings under the guidance of Dr. Swati Joshi ma'am. Contrast-enhanced CT scan of the abdomen was done outside on day 5 of illness. DICOM images were not available to us. These are the axial sections of the upper abdomen, showing major part of the pancreas appearing to be non-enhancing, with soft tissue stranding seen in peripancreatic and mesenteric region, and a collection measuring approx 14 into 11 into 11 centimeters involving the pancreatic, peripancreatic, lesser sac, gastrosplenic, and left paracolic region. There is also evidence of mild left pleural effusion and hepatomegaly with fatty infiltrations. Above findings are suggestive of acute severe necrotizing pancreatitis. Modified CT severity index has been used to grade the severity of pancreatitis. 4 points have been given for pancreatic and peripancreatic collection, 4 points for more than 30% necrosis, and 2 points for extra pancreatic complications, in our case pleural effusion and ascites, A total score of 10 has been given, indicating severe pancreatitis. Now I would like to invite Dr. Harshal to discuss the management of the patient.
Thank you, Dr. Diksha. Good morning, respected dignitaries, respected teachers, and my fellow residents. I will be presenting the management part of the disease. After the discussion and according to the Atlanta classification, we've reached up to a diagnosis of acute severe necrotizing pancreatitis owing its etiology to alcohol. We initially managed the patient in the late first week of presentation by keeping him nil per oral for 1 day and then starting him on enteral nutrition, IV fluids, antibiotics, injection ceftriaxone, which he was requiring on a regular basis initially for 2 days and then was kept on SOS basis. Oxygen support with nasal prongs for 2 liters for 2 days, chest physiotherapy and nutritional rehabilitation. With the significant improvement in pain and shortness of breath, patient was discharged after 7 days. Following this, the patient was kept on 2 weekly OPD follow-up for symptoms, blood investigations and serial USG whole abdomen to evaluate the size of collection along with nutritional counseling and most importantly alcohol abstinence. During this period, patient was off analgesics, however, he was unable to consume large meals. After 1.5 months, which is in the 7th week of his illness, patient presented again to us with complaints of pain abdomen, anorexia, fever and significant weight loss when weight dropped from 75 kgs to 60 kgs. Patient was again admitted for further management and his investigations at this time were as follows. He had mild anemia with hemoglobin of 10.2, neutrophilic predominant leukocytosis with counts of 20,900, a low serum albumin of 2.8, serum amylase of 480 and serum lipase of 620. I would like to call Dr. Diksha to discuss the imaging at this time.
Thank you, Dr. Harshal. Contrast and CT scan was done outside in week 7 of the illness. DICOM images were not available to us. As compared to the previous scan, we can see there was significant increase in the amount of the collection, now measuring approx 9 into 18 into 26 centimeters. Also, there is evidence of mild left pleural effusion and hepatomegaly with fatty infiltration as seen previously. MRI was also done outside. These are the axial pictures of the upper abdomen showing the similar findings as on the CT. No evidence of the communication of the collection with pancreatic duct was seen. I would like to invite Dr. Harshal to take the discussion forward.
Thank you, Dr. Diksha. According to the Atlanta classification, pancreatic fluid collections are classified as follows. In interstitial edematous pancreatitis, acute pancreatic or peripancreatic fluid collections are formed in less than 4 weeks of duration, which progress to form a pancreatic pseudocyst in more than 4 weeks of duration with a well-formed wall and no debris. Necrotizing pancreatitis forms the acute necrotic collection in less than 4 weeks of duration, which progresses to forms a walled-off necrotic collection in more than 4 weeks of duration, which has a well-formed wall with presence of debris inside the collection. The treatment options that are available for walled-off pancreatic necrosis are conservative, endoscopic, percutaneous and surgical. Our patient was initially kept for conservative management and then taken for endoscopic management. Comparing the endoscopic management and the percutaneous management, the latest literature and articles are in favor of endoscopic management because of better results, and surgical approach is usually delayed because minimally invasive approach is preferred. The therapeutic options available for walled-off necrosis are conservative, as we all know, keeping the patient on IV antibiotics. The drainage procedures include a percutaneous drainage or an endoscopic drainage. Then we have the necrosectomic procedures. A video-assisted retroperitoneal debridement can be done. A transmural endoscopic necrosectomy can be done, which was the case in our patient, or a percutaneous endoscopic necrosectomy can also be done. The open or laparoscopic necrosectomy is usually kept as a surgical point of management. At the 7th week of presentation, when the patient presented to us, a surgical gastroenterology opinion was also taken with an advice for conservative management. At 9th week of presentation, after 2 weeks, when the patient was kept on conservative management, his pain, fever, weight loss continued. His weight, which was 60 kgs, now further dropped to 54 kgs. It was at that time that he was counseled and an informed consent for therapeutic endoscopy was taken. Patient was hereby planned for endoscopic drainage of walled-off pancreatic necrosis with endoscopic ultrasound-guided lumen-opposing metal stent insertion with repeated sessions of endoscopic necrosectomy as the best standard of care with surgical backup. The stent devices that are available to us, firstly we have the double pigtail plastic stent which is available to us, used in the draining of benign biliary drainage procedures, and also is used to drain pancreatic pseudocysts. In our case, this would not have been the stent of choice because of the possibility of getting blocked by the presence of debris. Then we have the fully covered self-expanding metallic stent, which again is used in biliary drainage procedures and has a higher rates of migration because of lack of shouldering effect on both the sides. Then we have the lumen opposing metallic stent, which has shoulders on both the sides, approximates both the wall towards each other, and also has a wider diameter to facilitate the passage of endoscope and facilitates endoscopic necrosectomy through the stent. By this, the patient was taken for his first endoscopic intervention, which was LAMPS placement in the 10th week of his illness. An endoscopic ultrasound was done for the patient. The site of collection was identified. After identifying the site of collection, the presence of necrotic debris was confirmed. The distance between the cyst and the stomach was confirmed to be less than 1 centimeter, and the Doppler revealed no intervening vessels between the collection. The second image shows the delivery of the distal phalange of the stent inside the collection. This is the fluoroscopic image which shows a dumbbell-shaped stent after the delivery of the stent. The fourth is a endoscopic image which shows gush of turbid fluid in the stomach cavity after successful deployment of the stent, which was catheter suctioned and sent for culture. After this session, the patient was kept on for observation for 48 hours and was discharged with an advice for follow-up after 2 weeks. This is a videographic representation of what exactly was done. This is the stomach cavity, this is the cystic cavity, and this is the endoscopic ultrasound scope. This is the scope. A needle puncture was done from the stomach wall inside the cyst, and a guide wire was left behind. Over this, the stent delivery system was advanced. After advancing of the stent delivery system, the distal phalange of the stent was opened up inside the cyst. It was after opening up of the distal phalange of the stent, then it was pulled back so that the walls of the cyst and the stomach are approximated close to each other, and then the proximal part of the stent was opened up. After this, as we can see in the image also, the gush of turbid fluid came. Our patient was called for follow-up after 2 weeks, but he presented to us with pain and fever after 12 days. When he presented to us with these complaints, we took him for his second endoscopic intervention. On endoscopy, the cystogastroscopy site was identified and the lamps was seen to be migrated inside the cystic collection as on the fluoroscopy. After that, a CRE guided dilatation was done of the fistulous opening between the stomach and the cyst wall. After this, the gastroscope was advanced inside the cyst, necrosum, turbid fluid, and the migrated stent was visualized. The migrated stent was taken out, and after this, the debridement and removal of the necrosum was done using snare. Also, after this procedure, a nasocystic drain was placed inside the collection. We did such 3 interventions at 2 weeks of interval. That will be discussed also. Now I would like to invite Dr. Diksha to discuss the imaging.
Thank you, Dr. Harshal. Contrast enhanced CT scan was done in our hospital in week 14 of illness, post intervention by the Department of Gastroenterology. On the axial and the coronal section, we can see there was significant decrease in the amount of the collection, now measuring approx 5 into 9 into 15 centimeters. There is also evidence of left pleural effusion and hepatomegaly with fatty infiltration as previously seen. These are the VR pictures where we can see the stomach and the duodenum and the placement of the nasocystic tube going to the lumen of the collection via the stomach. The coronal section is showing the same. Now I would like to call Dr. Harshal for the further discussion.
Thank you, Dr. Diksha. In the 14th week of illness, In the 14th week of illness, when the patient was called after 2-weekly follow-up for his third endoscopic intervention, again in the similar fashion, the cystogastroscopy site was identified. This time it was identified with the help of nasocystic drain. After that, again a CRE dilatation, controlled radial expansion dilatation was done of the fistulous opening between the cyst and the stomach wall. The gastroscope was advanced into the cavity, and the debridement of the necrotic tissue and removal of the necrosum using snare was performed. After this session, the patient was admitted for 48 hours for monitoring. His nasocystic drain was flushed with normal saline and injection amikacin once daily for 2 days, and the patient was again called for follow-up after 2 weeks. In the 16th week of illness, he was taken for his fourth endoscopic intervention, which was the third session of endoscopic necrosectomy. Done in a similar fashion, this is the nasocystic drain from the stomach entering into the cyst. After the removal, this is the fistulous opening, which was again dilated, and the gastroscope was advanced in the cavity. This is the view inside the cavity. As we can see the nasocystic drain inside the cavity, along with significant reduction in the necrotic debris, as the imaging also suggested. And this was the first time that the viable granulation, pink viable granulation tissue was also visible to us in this. After this session also, he was kept for monitoring for 48 hours. His nasocystic drain was again flushed with normal saline and injection amikacin, and again was called for follow-up after 2 weeks. This time, on his 18th week of presentation, patient absolutely had no pain, no fever, also had some subjective weight gain. So initially his USG whole abdomen was done, which revealed a small peripancreatic hypoechoic collection of size 16 into 12 into 11 mm with a volume of 2 to 3 ml. It was at this time when he came at his 19th week, it was at this time when an endoscopy was done, healthy mucosa was seen, and endoscopic guided removal of nasocystic tube was done. The clean healthy mucosa was also visualized after removal of the nasocystic drain. A week after the removal of his drain, repeat ultrasound whole abdomen revealed no obvious peripancreatic collection and no significant abnormality. Coming on to the summary of management which we did for the patient. Initially in the month of August, when he presented to us, he was diagnosed with acute severe pancreatitis, managed conservatively. In the month of September, when he presented to us, he developed walled-off pancreatic necrosis, again was kept and managed conservatively. In October, when his walled-off pancreatic necrotic collection got symptomatic, we planned a LAMS insertion for the patient. After that, in October, when he was again taken for his endoscopy, his infected walled-off pancreatic necrotic collection, the migrated stent was removed, and his first session of endoscopic necrosectomy was done with insertion of nasocystic drain. In the month of November, again 2 sessions of necrosectomy, endoscopic necrosectomy were performed to facilitate adequate drainage of the necrosum, and in the month of December, his nasocystic drain was removed. The last follow-up that he did was in the 28th week of his illness, in which he had no pain, no fever, his appetite had improved significantly, he had gained weight from 48 kgs to 55 kgs, his functionality had improved, and he has resumed his work also. Now I would like to call Professor Dr. Akash Rajendra sir to further discuss the case. Thank you.
A very good morning, respected Dr. M. Sonkar sir, seniors and my dear friends. What makes this case unique is the fact that EUS or endoscopic ultrasound guided drainage followed by placement of LAMS and necrosectomy is a very complicated procedure, to the extent that it is done in only very few centers in the country. Even the guidelines suggest that it is to be done in centers with significant experience. Secondly, we were able to manage the complication of the migrated LAMS endoscopically. It is known to migrate in 5 to 8% of the patients in which it is used. Thirdly, we innovated the placement of a nasocystic drain, which helped us to keep the fistulous tract patent despite the migration of LAMS, and also in localizing the fistulous tract in subsequent endoscopic procedures. The rarity of this case can also be understood by the fact that only 20% of the patients with acute pancreatitis develop pancreatic necrosis, of which 1/3 of the patients develop infected pancreatic necrosis. 2 to 4% of the patients with walled-off necrosis require necrosectomy, for which a step-up approach has been recommended. In patients with pancreatic wall-off necrosis who are symptomatic or with infected wall-off necrosis, an EOS drainage or necrosectomy is recommended. In patients who have still ongoing sepsis or inaccessible collections, that is the collections in paracolic region, etc., a percutaneous catheter drainage is used as a step-up. If patient has still ongoing sepsis, VOD, that is video-assisted retroperitoneal debridement or open surgery, is recommended. The outcomes of surgical necrosectomy are not very encouraging, whereas endoscopic drainage and necrosectomy is supported by robust literature in form of 3 landmark trials. The first one being the Penguin trial, which was published in 2012, which compared endoscopic necrosectomy versus surgical necrosectomy, suggested that major complications and deaths were significantly higher in the surgery group, 80% as compared to 20% in endoscopic group. Also, organ failure and pancreatic fistulas were significantly lower in endoscopic group. Second trial, that is the Tension trial, was published in 2017. It compared endoscopic versus surgical step-up approach. Again, pancreatic fistulas were significantly lower in the endoscopic group. Also, the endoscopic group had a shorter hospital stay and it was cost effective. The third trial, which is a long-term follow-up of Tension trial, a 7-year follow-up, was published in 2022, suggested a lower levels of pancreatocutaneous fistulas, 8% in endoscopic group versus 34% in surgery, also lower interventions. It is always rewarding to see the patient sitting in your OPD just 2 weeks after the last endoscopic necrosectomy procedure, happily discussing his future plans. For which we thank the management of Mahatma Gandhi University of Medical Sciences and Technology for their support and encouragement, the Department of Surgical Gastroenterology, who always stood behind us in case anything went wrong, the Department of Anesthesia, who were always readily available for all complicated procedures, the Department of Radiodiagnosis, who were available 24/7 for the discussion of any clinical discussion. We sincerely thank the CCR Review Committee, especially Dr. Jaiswal sir, and most importantly, we thank the patient and his family members for this belief and faith they placed in us. Thank you.